This is Intraoperative Neuromonitoring Skill Building Module video number 4. In this video, we are going to talk about troubleshooting and optimizing intraoperative somatosensory evoked potential data. We want to troubleshoot and optimize best we can to prevent false negatives and false positives. A false negative shows no change in our intraoperative data, but the patient wakes up with a post-op deficit. A false positive shows a change in the data, but the patient wakes up with no post-op deficit. Both scenarios we need to try best we can to prevent. Our first line of defense is to have a good policy and procedure manual. It should be literature-based and cited. It should also be signed by all employees, the interpreters, and the surgeon. I've been asked to provide an abbreviated version to the surgeons in order to give them pertinent information that's important to them. It's also important when writing these policies to address each type of surgical procedure that you use somatosensory evoked potentials in, such as surgical cases where we need to identify the central sulcus, or the obvious spine cases, to name a couple. Our policy addresses what's monitorable and what's not, and we make sure everybody is on the same page. For instance, with cortical somatosensory evoked potentials, anything over a half a microvolt is considered monitorable. Anything 0.2 to 0.5 microvolts is considered marginal, and anything less than 0.2 microvolts is considered unmonitorable. You've probably seen this in other modules, but in addition to good sound policies, you should have troubleshooting flow sheets. In the heat of the moment, when everyone is standing over you and waiting for you to do your part after they took their time to do their part, wanting you to accurately apply 49 electrodes in 30 seconds, mistakes are bound to happen. With the anxiety of rushing, it's helpful to have these ready-made sheets because you may not think clearly in the heat of that moment. When there is a problem or a change, we need to speak in terms the recipient understands. For example, when you start seeing a change, if you go to the surgeon and say there's a change in the subcortical and cortical responses above the ERBS point on the left side of my SSEP, we know what their response is going to be. What does that mean? So in order to save time, we must adequately communicate in terms that the surgeon will understand. Say something like, on the left side, there's a response before the surgical site, but a significant change after the surgical site, indicating a non-technical change in the data. Emphasizing, indicating a non-technical change in the data. That assures the surgeon that you checked for technical problems first, and because you were reporting to them that this is something they must be alerted to. In the technical skill building module, I address things such as 60 cycle, stem artifact, and nodal blocking, and other things on a technical level that we can troubleshoot to fix our data. With this module, we're going to mostly address scenarios of changes. In this module, however, we're going to more focus on the data after technical problems have been resolved. Pay attention to the derivations and how the machine is programmed. This particular machine has the active electrode plugged into the second input and the reference plugged into the first. It makes a difference when you're on the fly trying to program because different manufacturers have their polarity convention, sometimes opposite. This is an upper SSEP. These are the baselines, the left side and the right side, your ERBS point, cervical, subcortical, and there's 2 cortical derivations. 45 minutes later, we see this. There's no change in the peripheral response or the ERBS point, but bilaterally, everything above has changed. It's important to point out that some of these waveforms today are going to be dramatizations like this one, and some of them will be real. Here's an upper SSEP, left side, right side, and you have a unilateral change with that peripheral response still intact. Here's a lower SSEP where we have the baselines up here, and later on we have the peripheral responses still intact, and on one side everything above that peripheral response is diminished. You want to get the troubleshooting sheet out and articulate the change. Is it left or right side? Which derivations? And what % change do you see? Quickly look at other technical problems that could cause this. Check your anesthesia values to make sure nothing drastic has happened there. And the key, is there a peripheral response? And the answer is yes. Since the answer is yes, you can bypass all this troubleshooting right here. We rapidly went through the checklist. We checked other modalities to see if they have changed as well. One thing we might want to do is check with anesthesia and make sure the patient's neck is positioned neutrally. If the head is cocked back too far, you can see changes, most of the times bilaterally, but sometimes unilateral, above that peripheral response. You want to report this immediately, as this could be a surgical change as well. Here's another upper SSEP, left side, right side. This is later on into the case, where you see a unilateral cortical change. Here's a lower SSEP baselines, left side, right side. Subsequent into the case, you see a unilateral cortical change in all three of the cortical derivations here. Subcortical looks good. The peripheral response looks fine. Articulate the change. Is it left or right? Which derivations? What % change do you see? Quickly go through your technical setup. Check with anesthesia to see if there are any problems there or anything drastically changed. Since there is a peripheral response, we can go directly to possibly thinking it's surgical. However, with this case, there is a subcortical response and it's only a cortical change. So maybe there's a perfusion or a vascular issue. We already went through the checklist. We looked at other modalities. We checked the neck position, and we report this immediately. If this is a vascular case, then this is something that probably should be immediately addressed. It's kind of a conundrum when it's a spine case, because you don't expect to see unilateral cortical changes. I've seen it a couple of times during my reign as spine queen for over 20 years. In both of those times, they've had a stroke during the case. So this is something that needs to be paid attention to. Chances are the patient's vitals are unstable at this point as well. I know in the cases that I've seen, the blood pressure was unstable. I like this slide because it's kind of real life. I don't always like showing perfect slides because that's not a day in the life of a neuromonitorist. This is more like what we see some days. There's a lot of things going on in this slide, like stem artifact, possibly electrode problems. But the reason I show this slide is we have to be able to read through messes like this sometimes. For instance, we're seeing a big change in the cortical evoked potentials. Here are the upper SSEPs, here are the lower SSEPs. Both corticals are diminished bilaterally. And in the lower SSEPs, all three corticals are also diminished bilaterally. It's important to do EEG to try to correlate these changes, specifically when you have bad data like this. You want to correlate with anesthetic values, of course, but you can also show through the EEG that obviously shows burst suppression here. It correlates with a non-surgical issue. Speaking of cortical responses, one way to boost cortical responses is to reduce the rep rate of stimulation. The red trace, I'm using a rep rate of 4.7 Hertz. I decrease the rep rate to 1.1 Hertz and then record it again, and that's the green trace. As you can see, the amplitude of the cortical responses almost doubled on the right, and on the left it increased by 0.7 microvolts. By reducing the rep rate, it takes longer to acquire these responses, so you have to decide whether or not it's worth it to forfeit turnover time in order to get better cortical responses. We had a series of 2 or 3 cases several years ago that occurred during lumbar fusions. These are upper SSEPs, the left side and the right side, cortical, subcortical, cervical, and the Erb's point. As you can see, bilaterally, all responses diminished. So I went through the checklist. The stimulator looked fine. The patient's fingers were twitching, so I knew I was on the nerve. There were no cold irrigations or infiltrated and leaking IVs. The surgeon or none of the staff, none of them were leaning on the arm. The blood pressure cuff looked fine. The arms were not taped down. There was not excessive packing in the armpit area or no recent adjustments to the operating room table. The lower SSEPs did not waver, did not change at all, and the limb temperature was stable. We decided to look at those chest pads of the new bed that we had just gotten. It's important to mention also that the pulse ox on the hand was reading in the 80s, and the blood pressure was very inconsistent from reading to reading. Here's a Jackson frame. This is the chest piece. This is where the hips go. And this is where the thighs go. And you can see the person on the frame on the left, how it's supposed to go. We all had training on how to position a patient on this bed. However, when you place the pads on, care must be taken when you put the patient on there that the pad stays in place. We found on the cases where we were losing upper extremities somatosensory evoked potentials that this pad was moving and bunching up and compressing in the armpit area. What we did is we put tape around the pad, not to compress it too much or it loses its padding effect, but tape it enough so it doesn't slip when we're positioning the patient. We also paid attention and made sure it was lower on the patient than what we were originally doing. As you can see in this picture on the left, the chest piece is rather lower. We think that we were positioning the patient too low on this piece, compressing that area. We developed a policy and a post-positioning checklist, and after implementing this, we did not have that problem again. Unilateral changes in the lower SSEP that includes the peripheral response or the popliteal fossa response can be the result of many things. You want to check the recording and the stimulating electrode placement. There might be too much break in the knees in the patient positioning. I've seen cases where the instruments or the Mayo stand is laying on the back of the leg and putting pressure on the legs. I've also seen cases where the leg fell off to the side and nobody knew it because they're under the drapes. A blood clot can happen. And if you're doing anterior lumbar cases where they're retracting that iliac artery, you can see changes in the lower SSEP that will mostly affect just the popliteal fossa due to decreased perfusion to the leg. We put a pulse oximeter on the toe to help detect problems like this. And the surgeon uses a retract and release type of a technique to where they're not continuously retracting that iliac artery throughout the case, contracting and then releasing, contracting, then releasing to ensure perfusion to the leg. During direct lateral fusions, the patient is laying on its side, and there's a risk of the down leg having too much pressure or being malpositioned to where you see changes in the entire lower extremity SSEP. Our peripheral response is important. Here's the left side, and then here's the right side SSEP, upper, and left side, right side, lower SSEP. This is 4 hours into a case of a thoracic tumor. As you can see in the lower SSEP, there's a bilateral change. The more prominent responses are the baseline, and the ones that are diminished are the most current. Bilaterally, there's a change in the lower SSEP. If we were not recording that popliteal fossa response for some reason, then you would have to go through a whole series of technical troubleshooting before you could get to the point to where it's probably a surgical change, wasting precious time of reporting a change when you can clearly see that there's not a problem technically because the popliteal fossa response did not change when the rest of the data did change. Optimization of SSEP. If there's no neuromuscular blockade on board, look for visible twitching in the fingers or the toes or the foot or wherever you're stimulating. Increase intensity until the amplitude of the peripheral response is maximized. We don't exceed 100 milliamps. Increase the duration. We don't exceed more than 500 microvolts for a stim duration. You might want to decrease the rate down to 1.1 hertz. Again, this forfeits turnover time of your data. If you're doing a lower SSEP, you might want to switch to perineal nerve or popliteal fossa stimulation if you can't get anything with the posterior tibial nerve. If it's all noise, you want to increase the number of reps until the signal-to-noise ratio is optimal. Usually greater than 2:1 is sufficient. Whatever you do to acquire your baselines, whatever parameters you may change, you do not change them after you get the baseline to maximize recognition of changes later on in the case. With respect to recording lower extremity SSEPs, you should do 2 cortical derivations, one at midline or at CPZ, and one recording at the side ipsilateral to stimulation or CPI. Because depending on the patient's dipole, that P37 response is maximal between the midline and ipsilateral central parietal scalp to stimulation. This article in Clinical Neurophysiology by Dr. McDonald and group talks about turnaround time of our data, stating the fastest possible surgical feedback, or about 1 minute between each trial, enables quick diagnosis and intervention. They define optimal derivations, enabling us to have a faster turnaround of our data as opposed to the traditional derivations. As a peripheral response, they use the cubital fossa as opposed to Erb's point in the median nerve SSEP. They also use the contralateral cortex reference to midline for a cortical. Here is the traditional montage that we do for median nerve. As you can see, 3 of them are referenced to the contralateral Erb's point. So it takes longer to average out noise that you're going to see because the electrode is over a muscular area. You can see after 50 reps, there's clearly, even sooner than that, reproducible data, and it's a faster turnaround for the information for the surgeon. I personally like seeing the cervical response and the subcortical response. I feel like it gives me more troubleshooting tools. However, for the sake of time and turning around your data, this might be optimal. The paper goes on to talk about traditional warning criteria pitfalls. They stress that amplitude should be the primary monitoring consideration with respect to changes. Demyelination that increases SSEP latency is less likely to happen in the OR. They talk about the 50% decrease in amplitude and how it risks false negative, meaning we may have a patient wake up with a deficit without any alerts. One of the ways to prevent this is to adjust from what they call baseline drift, or we may call it anesthetic changes. So after exposure and when anesthesia is on board and stable, you want to adjust your baselines to reflect what's on board at the current time. The ACNS guidelines state that a 10% increase in latency and a 50% decrease in amplitude calls for an alert. They also go on to say, though, that at 30% you should do an initial alert. Typically, a 50% drop in amplitude and 10% prolongation in latency is considered a significant change in the SSEP. But the key is the manner in which these changes occur, such as how it occurs and when it occurs. Is it an abrupt change or is it gradual? An abrupt change might be more alarming. Is it a change after a critical event? If that's the case, it might be more alarming. Short durational changes are less significant than persistent changes with regard to surgical outcome. However, smaller but clearly distinct changes may also be significant. So when you start seeing changes, you need to look at not only the numbers. Is it a 10% or a 50% change? You want to look at how the change occurred. Was it gradual over the last 2 hours, or was it just within the last 5 minutes? And when it occurred? What happened at the time that you see the change? All of it needs to be taken into consideration when making your alerts. I wanted to talk about common and random mistakes that we might make. Here we have a lower SSEP. Here's the left side and the right side. And as you can see, there's no popliteal fossa response. And also this cortical derivation, the transverse one where it's CPC to CPI, is inverted. It is most likely the case that the stimulators are switched. They're either switched on the patient or you plug them in wrong in the pods. It could possibly also be your programming. You could have programmed the wrong pod into the wrong side. Why is it not the case that the popliteal fossa is switched on the patient? And the key is because of the inversion of that cortical response. If the stimulators are switched and we're stimulating what we think is the left side, but we're actually stimulating the right side, the response is looking for left side popliteal fossa electrodes, which they never see, so there's no response. And it's also looking for that ipsilateral to stimulation cortical response, which will be programmed as CP3, but since we have the stimulator switch, it's recording at CP4. This will invert that cortical response, as you see right here. Now, if that response is not inverted, and you still don't see a popliteal fossa response, that's when you know that it's probably just the popliteal fossa electrodes are switched. If the popliteal fossa electrodes are switched and the stimulators are not switched, you're stimulating the right side. It's looking for the electrodes, but you have them programmed in wrong, then you're not going to see a response there. But everything else is going to be a normal response. This is a median nerve SSEP, left side and right side. Here's your cortical, subcortical, cervical, and your Erb's point response. And notice they're all referenced to that contralateral Erb's point. You'll see this kind of response when you have your Erb's point electrodes switch. You often see this type of recording when you have switched the plug-in or you've switched on the patient your Erb's point electrodes. You'll get that prominent downward deflection of an Erb's point in all of the derivations that have the Erb's point as the reference electrode. You're stimulating the right wrist, and the response is looking for the ipsilateral Erb's point electrode, but you've got them switched, so it's recording here and using a reference here, which causes that downward deflection. What happens when the CP3, CP4 derivation of corticals is inverted in your upper SSEP as well as your lower SSEP? It's possible that you have your electrodes too far anteriorly. In this case, the hookup looks fine. This is going to simulate the central sulcus, and we know the central sulcus divides the motor and the sensory areas. If your electrodes are too far forward, you may have a bifurcated, or even if they're very far forward, an inverted response. Here's your central sulcus. Here's the precentral gyrus, or the frontal area, and here's the postcentral gyrus, or the parietal area. Your N20 response will be maximal anywhere between C3 to CP3 or C4 to CP4. If you're too far anterior, you're going to either get a bifurcated wave or, like I said, even an inverted cortical wave. Let's talk about saphenous nerve SSEP. If you're writing a policy for saphenous nerve SSEP, I suggest these 3 publications to start with. They're very good on a technical level and have a lot of great information. The saphenous nerve is an extension of the femoral nerve, and an injury in surgery can cause sensory and motor issues. The saphenous nerve SSEP is recommended when the surgery being performed is a direct lateral interbody fusion or an extreme lateral interbody fusion, where the approach is lateral and the psoas muscle needs to be retracted to gain exposure to the disc space. Over here you can see where you would typically place the anode and the cathode if you're doing saphenous nerve stimulation. The saphenous nerve SSEP are smaller in nature because the nerve is deeper and the stimulator is farther away from the nerve. Some studies report an 81 to 97% success rate in getting saphenous nerve SSEPs. Others state that it's possibly a dermatome and it's not reliable, and that they are more susceptible to anesthetic changes than other SSEPs. We've had pretty good luck doing saphenous nerve SSEPs. Of course, you don't have a peripheral response or a response before the operative site. However, you can get good subcortical, and here's the cortical responses, left side and right side. As I said, we had pretty good luck with these. Why don't we do posterior tibial nerve or peroneal nerve stimulation for direct lateral cases? They've proven to be insensitive to changes during these types of cases, and I'll show you why. However, we should still do them because there's a chance of positioning problems with the patient laying on their side like this. And the posterior tibial nerve SSEP can pick up these changes due to positioning. Here's the pathway of the saphenous nerve, and you can see the information enters up higher in the spine. Here's the posterior tibial nerve SSEP, and right here you can see where it enters the spine. Enters lower through the lumbar plexus. And the same with the peroneal nerve. Here's where it enters, and it enters lower within the spine. In direct lateral cases, this psoas muscle needs to be retracted in order to gain exposure so they can do this inner body work on these discs. When they're retracting, there's a great risk to capture this femoral nerve and retract it and compress it, which is why saphenous nerve SSEPs are superior to doing posterior tibial nerve SSEPs during these types of cases. This paper by Mike Riley and group also point out that the femoral nerve innervates the quadricep muscles. So it's important to also supplement with saphenous nerve SSEP with transcranial motor evoked potentials and record from the quadriceps to better capture changes. Troubleshooting and optimizing saphenous nerve SSEP. If there is no neuromuscular blockade on board, look for visible leg movement. Check other modalities because with saphenous nerve SSEP, there's no peripheral response to validate stimulation. Increase stimulation intensity up to 100 milliamps. Increase stim duration in increments of 100 microseconds up to 600 microseconds. This might seem high, however, remember this nerve is deeper and it might take more juice to activate it. Decrease the stim rate or the rep rate down to 1.1 hertz and increase the number of reps of average if it's a noisy response, which these tend to be. Let's talk about using SSEP and trying to identify the central sulcus using a phase reversal technique. We know that the central sulcus divides the sensory and the motor tracts. During cases where a tumor might distort the anatomy of the patient, and the surgeon needs our help into identifying what's motor and what's sensory, an electrode might be placed directly on the brain. This particular electrode has 6 contacts, and we plug it into our machine on our end. We do a median nerve SSEP using each contact and referencing it. We're using a referential montage, and we look for an N20. Remember earlier I said that if you go over to the motor side of the central sulcus, that N20 or that cortical response might invert. And that's what we're looking for, that inversion, that crossover. It's important to note that you have a control to validate stimulation. So this first channel is an Erb's point electrode, and they're doing an Erb's point response to validate stimulation. And the rest of them are cortical derivations. Here's your N20, your N20, your N20, and you see right here is where it inverts between electrode 3 and 2. We've helped the surgeon determine where the motor versus the sensory tracts are. Sometimes it's not as easy to identify as that first case that I just showed you. One would guess it could possibly be here, in the second example possibly here, and in the third example possibly here. And you see all of these have a good Erb's point in there to validate stimulation. Let's talk about optimizing this response. If you have poor quality data, if there's no neuromuscular blockade on board, look for movement with stimulation. Make sure those fingers are twitching. You can increase the intensity or increase the duration, but you got to be careful because sometimes these cases are done with the patient awake. And if they perceive any pain, of course, you're going to get an increased muscle activity. You also can decrease the rep rate to try to enhance that cortical response. If there's a lot of noise, it could possibly be that the area needs irrigated with warm saline that might have dried out. You also might have contamination from a defective contact on the strip, so you may have to just disable that channel. What type of montage should you use? This is referential versus a bipolar montage. In a referential montage, as you've seen earlier, the central sulcus is identified by looking at the N20 and the P20, and they point toward each other. If you use a bipolar montage, the central sulcus is identified by looking at the N20 and P20, and they point away from each other. The examples I had earlier used a referential montage, and they were referencing to FPZ. In some cases, you can reference to the mastoid or somewhere off the head. In the bipolar montage, you reference contact 1 to 2, 2 to 3, and so on. There's a common electrode in any two derivations. And don't forget the Erb's point electrode to validate stimulation. What happens when you see this? These are all N20s and they're all pointing the same way. If they're all negative, meaning they're all on the sensory strip, we need to move the strip forward or more anteriorly until you see that phase reversal right here. So here, all those contacts were on the sensory strip. We simply just move it anterior. And then the opposite is true as well. If they're all positive pointing, then you need to advise them to move the strip posteriorly. If you're not getting a response at all, sometimes you have to move the contacts laterally as well. It's not always an exact science. Remember, these patients' anatomies are distorted. Lastly, in the SSEP module, I wanted to talk about waveform management. This is one of my pet peeves. I recently took on a job, or last few years, took on a job as a remote technical supervisor. My job is to help newer technologists out in the field when they go on their own. When I see something like this, it kind of drives me crazy. It gets my OCD acting up. You need to organize these labels so that they're not in the way and they're not obscuring your data. Adjust your gains so that you can actually see the data channel by channel. This is an actual case that I had to look in on. I'm not sure how you can determine if a change occurred or not by looking at this. Much better. Make sure you can identify each waveform channel by channel. The labels are out of the way. You can clearly see what you need to see. And your remote supervisors can quickly help you should you need any help technically. The remote professional interpreters also appreciate this. This allows for fast interpretation of data. With the SSEP, you should amplify the left and the right equally to show asymmetries from side to side. Clearly show the amplitudes and latencies and manage your labels so they're not obscuring the data. Show your sensitivity or your gain and your time bases on screen and other things like stem parameters for your remote supervisors to better assist you. The gains aren't on here. However, the time base is. It's 5 milliseconds per division. You can clearly see the latency markers, and here's the amplitude markers.